Sometimes we actually measure the top of the fundus to see if the fundus is going up, because she may be bleeding into the uterus. You know that with an abruption, she may not be overtly bleeding. There may not be much of anything more than bloody show on the pad, because the bleeding can all be trapped inside the uterus. So the uterus may be getting bigger and bigger as she's hemorrhaging into the uterus. So first, with hypertonic contractions, that has to be ruled out. Okay. And we're not talking about Pitocin making hypertonic contractions. Obviously, if you run the medication that's stimulating the uterus to contract too fast, or the patient is particularly sensitive to it, you could make hypertonic contractions and cause the same problem, maybe not getting enough oxygen. But let's say, and this tends to happen more with a primip, that she's having these really hard contractions every couple minutes. She may have been in labor for 3 to 8 hours at home already with mild contractions, and she was excited, and she couldn't go back to sleep, and it was the middle of the night. Now it's 9 or 10 in the morning, and she's tired, and she's having these hard contractions, and you're the nurse, and you put on your glove, and you do the vaginal exam, and the cervix is big. How does she feel? She wants to jump off a high building, okay? She wants this over. It's not happening. What's the matter with my body? How come I'm not dilating? These contractions are so bad. I never dreamed it could be this hard. So that patient may get an early epidural just because of the fact that the contractions are strong, but they're ineffective. That's the key thing here. They're not making a difference. So for hypertonic contractions, if it were the morning, one of the things we might do, if we were less interventionist, is put her in a hot shower, help her to relax. Use the breathing techniques. Use massage, use effleurage, all those neat things, and talk with her and help her try to relax a bit so that her body can work more effectively. If it's bedtime, and she's been doing this for a long time, what she may have ordered for her is a little bit of a relaxing drug along with a sleeping pill. Thought being that if she just gets to relax and gets a few hours of sleep, hopefully she'll get back into an effective labor pattern. Now we have the woman who is having contractions every 3 minutes, and they're lasting 20, 30 seconds. They are hypotonic, and they're not doing much of anything. Again, it tends to be more a primip. First babies are tougher, no way about it. So what could we do for this woman if we're the nurse taking care of her? We want her to get stronger, more powerful contractions. And yeah, I know Pitocin's out there, and we can use it, and we're going to talk about it. Besides Pitocin, what else could we do to help her body work more effectively? Walk. Get this woman up and moving. And maybe she's dehydrated. Give her ice chips, give her popsicles. If she's allowed to have it, juice. Now, each hospital is a little bit different on what they allow with fluids. I'm at Shady Grove. Unless there's a contraindication, they're allowed popsicles, they're allowed water, they're allowed any clear liquid in from the neighbor. Some hospitals have different policies. So dehydration interferes with the ability to have good contractions. There's always the good old IV. But getting up and walking, sitting on the labor ball, rocking, those are things more likely to put her into a more effective labor patient pattern. We talked a little bit about prolonged pushing. That it's okay as long as mom has the energy to do it and baby's tolerating it and you're making progress. And last but not least, there are those women who have precipitous labors and delivery. In this 7 weeks of the hospital where I worked, there was a patient that came in who had delivered in the ambulance on the way to the hospital. Sometimes women deliver in the car along the beltway. Sometimes they deliver in the kitchen, on the kitchen floor. Do you think they're happy or sad about that? Happy that they got it out? Okay. I think the range of emotions is as wide and varied as there are people. There are those who feel really let down that they didn't get to follow their birth plan and things didn't go as anticipated. And particularly if there's any complication that comes from that. And one of our questions to them would be to tell me how you feel about this. You know, our good old open-ended communication questions. Because you can't just assume that because the baby was delivered quickly that they're really happy about the whole thing. There are risks for the mommy and there's risks for the baby with a precipitous labor and delivery. So let's first of all talk about what we would do if we are the first responder to a precipitous delivery, and then let's talk about what those problems are. I'm good Samaritan. You are driving along the Beltway, and it's the middle of the night, so there's not a lot of other cars around. Otherwise, you'd be jammed in so much traffic, nobody would be able to flag you down, okay? But there's a daddy over at the side of the road, and the daddy looks frantic, and he's jumping up and down, and he's trying to get you to come over to, or anybody to come over to help. And so you're the Good Samaritan, and you pull off the side of the road along beside him, and there you find a pregnant woman either laying on the ground, or hopefully she's in the back seat of the car. It's hard to deliver in the front seat of the car. There's just not enough maneuvering room. So you're there to help. What would your role be? First of all, you could pull out your handy-dandy gloves that you carry with you every time. If you go anywhere, right? Maybe not. I guess in my own personal decision-making tree, I really wouldn't worry a whale of a lot about that. If the head is crowning and it's rocking like it's going to come out, but it goes back in when the contraction goes away, the best thing that you can do is not hold the baby in, but place your hand on the top of the head so that it comes out slowly rather than okay? Because that really forceful expulsion is more likely to cause a problem for the mama's tissues. So you're not holding the head in, you're just putting gentle pressure on the head as it delivers. Those babies that precip nearly always come out with screaming, crying, everything's A-okay, looking fine. Nearly always. So you're not going to have to do a whale of a lot else as the baby slides out. I would never touch the umbilical cord. And I'm telling you the same thing that when I taught childbirth classes, I would tell the people in the class, don't mess with the cord. You don't have to cut it. You never want to cut it until it's been tied or clamped. And you really don't need to do that. If the cord is long enough, the next thing you want to do is dry the baby off, because don't we have to worry about cold stress? So dry it off with whatever you got. Maybe somebody takes off a shirt, or maybe there's a coat, or whatever. Dry the baby first. That stimulates the baby, and if it wasn't screaming already, it will be as you dry it off. And the second thing is, I don't care whether she's planning to breastfeed or not, baby needs to go to breast. Because going to breast, it's going to help the uterus contract down, it's going to aid in the release of the afterbirth, and it's going to control bleeding. And then, assuming the person that's with her has a cell phone and dialed 911, you're going to have help before you need to do much else. That's delivering in the Washington, D.C. area where there's rescue squads readily available.
What about the placenta that follows the baby?
If it just falls out, you're going to get help there. I wouldn't even touch it. It's messy. You didn't have gloves. Pretend.
But it's not attached anywhere. I know it's not attached to the uterine wall, but
It's not attached to the uterine wall. It's still attached to the baby until somebody cuts.
with the cord.
With the cord,
Okay.
yeah. There is some risk of reverse transfusion from the baby to the placenta. I wouldn't worry about it. As long as you've got your baby to the breast, you're going to have help soon enough not to have to deal with that. Okay, so this baby that came, lickety-split, what risk is there to the mommy?
Lacerations.
Lacerations, okay. Because it wasn't a controlled delivery, or maybe it wasn't controlled. Maybe she was delivering as you got there. You couldn't put your hand on the top of the head and let it come out slowly. So yes, lacerations, and they can be repaired when she gets to the hospital. If it's a tiny little tear, sometimes they don't even put a stitch in. Any other risk to the mommy? Hemorrhage, all right. We'll talk about that in connection with postpartum complications, but bottom line is, with a precipitous labor and delivery, assuming she just didn't stay home until the last minute and she had an average length labor, assuming it really was fast, 2.5 hours or less, then the uterus never got into that rhythm, contract, relax. Contract, relax. So the baby's delivered and the uterus just, I'm done, and it becomes boggy and relaxed, and then she bleeds heavily. So the biggest risk for mom, even more than the laceration, which can be dealt with, is a postpartum hemorrhage. Any risk for baby? What? There is potential that it could have a problem with needing to have a bulb syringe used or something. I've never seen it happen. The only exception of that could be if the cord was around the neck a few times, really tight, and then someone is going to have to try to loop the cord over the head and slide it off. And I've never seen a precipitous birth with the cord around tight 2 or 3 times. Could it happen? Absolutely. Statistically, it could happen. And then somebody would have to clamp and then cut the cord to be able to deliver the baby because it's basically being strangled by the cord. I've just never seen it happen with a precipitous birth or really heard of it happening. Risk to the baby is that if it were a very premature babies aren't normally delivered vaginally, they're delivered by cesarean, so as to avoid pressure on the head because their skull bones are so soft and there's that risk of intracranial hemorrhage. So if it was a very small preemie, that's a risk for the baby. That's about the only one for the baby. Okay, we've gone through power and problems with labor. Problems with the passenger basically have to do with at least in part, with the position the baby's in. First one on that list is posterior. And I'll show you the position that I love for a baby that's posterior. I showed my clinical group, and I'll show you guys. For someone who's having a lot of back labor, the position that tends to be the most comfortable is having her over that table in front of her, put a pillow there, and lean her forward like this. Because what happens when you lean forward? Where's the baby go? Forward and off your back. And when it's forward, it has a better ability with contractions to spin and turn around that position where it becomes anterior. So leaning forward is a great position. And you can do this one with an epidural. Another awesome position for a posterior is hands and knees. And that one is virtually impossible to do with an epidural. Really, really tough. I remember a lady that I was working with in labor and delivery, and she was a graduate pre-para too. She had delivered 2 babies previously that were average size. This one looked considerably bigger. And she was trying to push the baby out with the baby still being posterior, and it wasn't happening, and she was getting really tired. So there were 2 nurses, myself and one other, and we talked her into, with her support person's help, getting up onto her hands and knees. And we said, when you're on your hands and knees, the baby may spin around as you push. Go ahead and push when you feel a contraction. Well, I'm telling you, we got her on her hands and knees. She had a contraction. She pushed, and that baby spun around so fast that we barely had time to get her back sideline so that the midwife could catch the baby. Because just getting her in that position freed the baby up from that position where it was locked with the back of its head against the spine, spun around, and down and out it came. It was beautiful. And you can't believe how impressed she was with her nurses and knew how to suggest that. That's something neat you can just put without for any of you that eventually plan to work in labor and delivery. A lot of you don't. That's okay. Breech position. You know what the breech is. It comes in different versions. It can come with its little legs up over its shoulders. It can come with its legs crossed. It can come with its legs extended so that one foot comes out first and one foot's inside, or 2 feet coming out. One foot is called a footling presentation, 2 are double footling. Makes sense. If it is a first-time mother in this country, she will not be delivering vaginally unless she somehow gets a home delivery and somebody who is going to work with her doing that. And why is that? Say again? Lawsuits. Okay, and why would lawsuits be a possibility? What's the risk here? You're on the right track. Absolutely. Did you hear what she said?